Good morning, everyone. It's Jason Anderson here from Medmont, Australia. I'd like to welcome you to this webinar, and hopefully you'll learn something about your Medmont topographer. I'd like to introduce Randy Kojima. Randy, over to you.
Thanks, Jason. So this talk is going to be about Medmont topographer tips and tricks. And the idea is, if you're a beginner, I hope there's going to be some things in there that will take you into more of an intermediate status. For those of you who are intermediate or advanced, I know in Australia you're the most experienced Medmont users and topographer users in general, but I hope there'll be an item here or there that maybe you can incorporate into practice. So let's begin with the composite, and I believe so strongly in this capture. It's so beneficial in cases where we're not able to get the coverage that we'd like. This particular case is a good example where we have a relatively small fissure patient and a generally small person. It was an adult, but really, really small features. And the eyelashes and the lids were in the way, and that really hindered our ability to get information on the peripheral cornea. But it's incredibly high toric eye, and being able to use that composite feature really fills in the information, gets us out to almost 12 millimeters of data. So for any of the modern lenses we fit, and Aussies and Kiwis are the best on the planet for using larger diameter lenses. Of course, if you're fitting an Ortho K that's 11 millimeters, kind of helpful to have data out to at least the point where the lens begins its alignment, and that's usually around 9 millimeters. So if we could get from 9 all the way out to the lens diameter, that would really be great. For our conventional GPs, our single vision and our presbyopic lenses, having that peripheral corneal information, of course, it's valuable. And then for scleral, we'll talk about why you can use the corneal topographer to actually fit a scleral lens and how the composite factors in so strongly to this story. So one of the things that Jason and I wanted to share with you is a different way to capture. Many of you would be familiar with the composite, and using the wizard just walks you right through step by step how to get that big, large view of the eye. Now, once you understand the wizard, you really don't need to use it. You could manually connect maps together. You could take more than just the 5 and average out a large number if you were really worried about getting quality data. So that's what I do. I do 2 captures on the visual axis, 2 on the geometric, and then I'll do the 4 captures in each of the different directions. So 1 map, nasal, 1 temporal, 1 inferior, 1 superior. So the way that works is you have your 2 captures on the visual axis, patient simply looking right down the axis of the instrument. The benefit of this is you understand what does the patient actually look through, what powers are distributed within the pupil that are along the line of sight. However, the geometric axis gives you an understanding of if the eye has any natural displacement. Should you expect the lens to go nasal, temporal, superior, inferior? The geometric axis really gives you an understanding of the corneal shape relative to the visible iris. Now, how do you get these 2 captures? And that's confusing for somebody who's never done it. The visual axis, so easy. You're just going to look right down the axis of the instrument at the center ring. No real mystery to that one. You've been doing that with all your patients from the beginning of time. Now with the geometric, you're attempting to move the placido off the nasal side and moving it more toward the temporal, and ideally geometrically centered to the visible iris. So to do that, you have to ask the patient to look maybe 1, 2, 3 rings toward the nose. Sometimes it's more than 3, sometimes it's not even a full ring. You just have to ask the patient to fixate and then look at where these placido reflections are and move the eye nasal or temporal as required, or more towards center or less towards center as required. Then your final captures are your various fixations, and the idea behind these, of course, is to push the ring data up to the top. far out to the temporal side, inferior and far out to the nasal side. And ultimately, being able to get that peripheral corneal data gives us kind of the big picture of corneal shape, not just the center, but the periphery as well. So now I have 8 captures. I have 2 visual axis, I have 2 geometric, and 1 in each of the principal directions. I'm going to just highlight all of those maps and go to Analysis and Composite Eye. So this would be a manually constructed composite, not using the wizard. And I kind of like this because it allows me to do my own types of captures. Number one, I have all the various fixations if I ever want to refer to them. And the other thing is that I'm merging 8 different topographies to create one rather than merging 5 different topographies to create one. And this is kind of beneficial because the more data points you're averaging out here in the center, the more likely your central data is finding the mean of eye shape and possibly more accurate. So this composite capture is really the number one reason, at least in my mind, to have a Medmont topographer, to be able to assess that much of the cornea. It's just so beneficial for so many applications. Now, should you do a composite on every patient? And the answer is definitely an emphatic no. I would not do a composite if you were doing a screening. Are you wanting to know what orientation of astigmatism? Are you wanting to do a disease detection analysis? You don't need a composite. Are you building a rigid contact lens? Yes, you definitely should use the composite. Are you using, are you wanting to build an Ortho-K lens? Then yeah, you definitely want to use the composite. Because it's going to give us such a large diameter of capture, then we're able to use the contact lens software to construct the lens from edge to edge. And even if the fixation isn't 100%, we're still extending data past the diameter of our contact lens. So really, such a valuable tool. There's a study that published in 2018, and the full 2-year data should publish fairly shortly. And it showed using the Medmont Topographer with Ortho-K lenses with a software constructed lens. So based on all the data that Medmont comes up with, they had a 95% first fit success using good quality Medmont topography and using fitting software for Ortho-K. So pretty awesome outcome, 95% first fit success. Now, what do you see in this capture? And of course, you notice that the blue is significant on the nasal side, where we really see very little of that equal flattening on the opposing side. And this is your visual axis capture. And you'll notice that the cap of the cornea, this yellow-green border, appears to be pulled very much temporal of the visual axis, which is right here in the center, or certainly temporal of the pupil, this black circle here. So if you were to start orthokeratology on this patient, you would say Ortho-K lenses should decenter temporally. The cap of the cornea is temporal of the visual axis or the pupil. Well, part of the story is that, of course, the topographer is always mapping farther to the nasal side due to angle kappa, and we've got this off-centered fixation in relationship to the visible iris. So by moving this placido onto center, we'd have a better understanding of natural eye displacement. And here, with a visual axis capture, you notice the rings really hit the nasal side, and we're completely missing what's happening out here. And this is true of any instrument that's mapping on the visual axis. So what we want to do is try to center up that placido to understand the natural eye displacement. And by taking our photo on the geometric axis, we'll have that understanding. So how do we do that? Again, we're going to ask the patient not to fixate down the center, but go from the center 1, 2, 3, 4 rings over so that we move the placido centered to the iris. Now, what does that tell you? Here is our visual axis capture, rings on the nasal side. Here's our geometric capture, rings centered to the iris. And you would say that this eye shows a natural temporal displacement. But when you do a geometric capture, you actually see the contours appear relatively symmetric laterally. Arguably, our lens should possibly favor a little nasal displacement. I think the distance from the center to the yellow-green border is a little farther in this direction than it is in this direction. So an ortho-K lens on this patient should actually favor a slightly nasal of center fixation, which would be good, especially considering that our visual axis is nasal of center. So hopefully that makes some sense that using visual axis is valuable to understand what the patient looks through, but using the geometric axis will tell us where will the contact lens favor its centration? Where is it likely to want to go? Now, when you want to build an ortho-K lens, there's a function in the software that really helps you to build an accurate first lens. You're going to take your topography, ideally a composite, but if you weren't able to get one, then you can use a single or multiple maps, whatever you have, and then go to Analysis and Ideal Eye. And what that's going to do is create this excuse me, very symmetric surface. So the nasal and temporal will be mirrors of each other. The superior and inferior will be a mirror. So even if there's a degree of asymmetry, the Medmont software will turn the eye into this perfect symmetric surface. Now, why does this have value? Why would we want to take the real eye shape and convert it into this false eye, this ideal eye? And the reason is when we use the Medmont contact lens software, we can predict the parameters of the lens, but no software can predict where a lens will find its equilibrium. And being able to use this ideal eye is really helpful in lenses like Ortho-K, where they need to be micron accurate. So I build all of my Ortho-K lenses off this ideal eye, and it gives you a very accurate prediction of the initial fluorescein pattern that you're going to see on eye. Because an Ortho-K lens, it can't be off by more than a few microns. So if you don't know the natural tilt or decentration that lens might take to find the equilibrium in the periphery, where the matching alignment zone finds the matching surface shape, then your pattern won't be as predictive as you hope. So that's why this ideal eye is valuable. Now, do I use the ideal eye on a conventional GP? And I don't think it's necessary. A corneal GP for single vision or multifocal application, it's upwards of 20 microns of fluid under the center. So it has a certain degree of slop or error that's possible. Whereas an Ortho-K lens, we're fitting a reverse geometry shape that requires the alignment zone to be just right, the depth at the apex to be just right. So a reverse curve has to be appropriate. There's a lot of things that need to be correct. So this ideal eye is helpful, specific again to the Ortho-K lens construction. And when you get a map like this, where we have some funny looking information, and you might focus in on this blue area right here. Notice there's this deep area of flattening where the eye just drops off the cliff in curvature, creating this flat spot. Whereas the eye in the opposite direction seems to follow this natural rate of flattening. And that might make you suspect that this is garbage information. If the slit lamp was negative for any signs there, if the placido reflection was good, then one would presume that that must be the real eye shape. But if we're not sure, it might be helpful to look at the placido reflection. And what you can see is that I completely blew it. I let there be a whack of ring distortion, possibly from tear film breakup, that completely messed up all of the data points in this area of the topography. So it's creating false information. So what we can do is try to edit out those points. Medmont will allow us to get rid of those data points and reassess the eye shape. So this can be valuable if you've got a patient that's driven 2 hours to the practice and you didn't have time to build the lens while they were there and they're now gone. So you can go back and fix up your poor topographies. And that's obvious here in this lens that I just attempted to design off that topography. Notice how the lens has this incredible bearing on that high point, and it finds its opposing point of bearing arcuately across here. But if you remember back to the topography, it's a with the rule corneal astigmat. So the most bearing should be across the flat meridian at 3 and 9 o'clock. It shouldn't be at 10 o'clock and arcuately across the inferior cornea. So I think there's something wrong with this analysis. So what we can do is edit, and we can go to Analysis and Edit, which will bring up all the data points that were collected by our capture. And what you're going to do is just erase out all of these points that you're suspect of. So notice I've put my cursor over all of these data points, turned them from white to black. It's basically eliminating them from the analysis of this topography. Then you can go up to Analysis and remove selected points, takes them out of the interpretation, and you're left with the topography without those erroneous areas of the map. So again, I believe that this is the real shape of the eye because I saw so much ring distortion here where the actual epithelial surface looked normal and there wasn't any history of anything that had happened in that area of the cornea. So I don't trust the topography map I took. And if I would have done a better job, taken more time, asked the patient to blink regularly, possibly put in artificial tear if I couldn't smooth over that area because of dryness. You know, these things I should have attempted but didn't. And that's where this edit function is helpful. So you can see now, after reconstructing the lens without that area of possible false information, I get a theoretical fit that looks absolutely normal on a with the rule astigmat. I get a lens that lands at 9 o'clock, lens that lands at 3 o'clock. We've got that nice little channel running through the vertical meridian. We don't have this high point where the lens may be thrown off by that high elevation. So the contact lens software is this awesome tool, and if any of you are really keen about building contact lenses and constructing the lenses yourself, this is such a tool to build virtually anything from a scleral lens all the way down to the smallest corneal GP lens. Today's talk won't focus on building rigid lenses. There's a number of videos that Jason Anderson from Medmont can share with you, or you can go to the Medmont website. It has building single vision corneal GPs. It's got building ortho K lenses and scleral and so on. So you can use those tools to learn how to use the contact lens software. Now, some folks I've seen using the 3D function, it may be missing a valuable tool that might help. So you have typically the two-dimensional view in planar, and that's the way you would normally look at your topographies. And virtually 100% of the ones that we use in analysis in the clinic and with patients are the planar. But when we're trying to show something irregular, the perspective view can be kind of helpful. So what you'll do is just click on perspective and it'll give you more of a 3D view. Remember that when you're using an axial or tangential map, you're not looking at the eye elevation in 3D, you're looking at the curvature or shape of the eye in 3D. So that may not equate to the highest point or the lowest point. It may just equate to where is the cornea most curved or least curved. But you see the problem here is we really have zero perspective to how the eye might change. So we need to adjust this perspective scaling value that you see right here. let's change that number until we get a more obvious appearance to this patient's keratoconus. So we'll crank it up to maybe 30, and now we're seeing a very obvious peak and curvature to this eye, how the inferior cornea has such a massive change in radius where the superior cornea really doesn't. If you right-click on top of the topography and select your pan view, then you can modify the axis that you're looking at this topography. So you can change your perspective angle. Now, does this have any value to you as a clinician, for you to work with a contact lens, for instance? And I would suggest to you, I haven't found one. The real value to using the perspective scaling is for patient education. You're trying to explain to a patient why their best corrected VA is nowhere near 6.6, and this might be one of those helpful tools that the instrument does for you. All right, let's have a look at a kind of cool topography. Here's a patient that's 4312 by 4438, 1 1/4 diopters of corneal astigmatism. So for anyone who thinks in millimeters of corneal sill, that's about 0.25 millimeters of corneal astigmatism. Now, if you had a patient with that low a degree of corneal sill, would you think that a toric rigid lens would be required? And of course, when we think about corneal astigmatism, we're measuring this 3 millimeter ring right here. And that's not describing what's happening anywhere where the lens actually needs to touch down on the eye surface. Every rigid contact lens that you ever fit is going to be vaulting through the central corneal tissue. So this 3 millimeter ring of astigmatism really matters very little relative to where my contact lens has to find its equilibrium, its alignment, its landing with the eye, way out at 8, 9, maybe even 10 millimeters. So we need to understand the peripheral shape of the eye, and that diameter will depend on the optic zone of lens that you're using. So if you favor a more traditional 9.5 diameter lens, its optic zone is 8 millimeters. That's where it's going to land the heaviest. If you're using a 10 millimeter lens, its optic zone is probably going to be closer to somewhere around 9.5. If you're using an Ortho-K lens at maybe 11 millimeters, its bearing point is going to be very much closest to around 9 millimeters. Sorry, if I said a 10 millimeter lens should have a bearing at 9, it's more like 8.5 millimeters. Apologies. So 9.5 would land at around 8 millimeters. 10 millimeter lens would land at around 8.5 millimeters, and an Ortho-K lens would land at around 9 millimeters. So we really want to push our analysis far out to the peripheral cornea to understand what we're dealing with for toricity or irregularity. The way to do that is to go to the Analysis Details window in Medmont and pull up this window right here. And what that does is give us a little more data than the main attribute window might provide, and we can control the information that we're looking at. So for instance, the first step is to decide, where is the chord of bearing of my rigid lens? Where does my lens touch down and land? And that's around 8 millimeters for most contact lenses. So if I set my 8 millimeter diameter, now I'm measuring the height of the eye from this 8 millimeter chord to the peak. So then I can click on the flat axis and record the weighted average height. That's basically the sagittal depth. Medmont is one of the few topographers that gives us sag, not eccentricity to understand height, but the actual raw sagittal depth, the height of the eye. So we can click on the flat meridian, click on the steep meridian, and now we have the two values for the flat and steep, the principal axes. That gives us a measurement and a comparison of the differential between these two. In this case, there's 50 microns of differential in height. Now, that was a bit of gymnastics to go to analysis, details window, set my chord at 8 millimeters, click on the flat, record the number, click on the steep, record the number. Jason and the Medmont team have created this attribute that you can put on your main window. It's accessible from the newest Medmont software. You just highlight that you want it on your main window. So I've got this number up here, and every time I'm fitting a rigid lens patient, it's the first number I look at. I actually don't even look at the corneal astigmatism first. I'm wondering, how toric is the peripheral cornea? Do I need a symmetric or toric landing? And at around 30 microns at an 8 millimeter chord, that's where the threshold of a toric lens is usually called for. Meaning, if you have less than 30 microns of sagittal differential, a symmetric ortho-K, a symmetric corneal GP will work generally just fine. If you're over 30 microns at an 8 millimeter chord, then you want to consider using a toric landing. Now, just for a second, let's review the attribute window. And there is a whole lot of information that's available to you. What do you actually want? And if you go to this arrange icon, this up-down arrow at the top of your attribute window. So that's right here on your main analysis window. Click on that button, and what it'll do is it'll bring up this window, and you can scroll down through here and look for the various attributes that Medmont has created to find ones that you might use most often. In my case, when I've found something, I just click on it and then click on the right arrow. I move it across to my main window. Then you can use these up and down arrows to move the ones that you use most to maybe the top, and the ones you use least down to the bottom, and put it in a logical progression. Now there's also this icon that allows you to create your own attributes. So if you're the programming type, if you're pretty good with your math, you may want to create specific attributes for the specific contact lenses you use, or Jason and the Medmont team can help if it's something that you're trying to get to but really struggling with. Jason would love nothing more than to spend his Saturday night building attributes, so don't be afraid to reach out to him. Now, when you look at the attribute window, you can see I've loaded up a whole lot of different attributes, and I want to share some of them with you to see if maybe one or two of them might have some value to you in clinical practice. Now, of course, the K readings are always given, and we care about that because we're curious of the radius of the eye, how steep or how flat it is. Is it likely to be more toward the disease side? Is this a good candidate for ortho-K? Steeper corneas, we know, tend to be better ortho-K candidates. The eccentricity value is important because we know that in ortho-K, the higher eccentricity eyes tend to respond better than lower eccentricity eyes, especially when we're dealing with high refractive changes. Another thing you can look at is the difference between these two. When the flat E and the steep E are significantly different, that's telling you you have a more limbus to limbus corneal astigmatism. You have a bigger differential between the depth of the flat and the depth of the steep. So without looking at sagittal depth, if you see a huge differential between these two numbers, you know that the rates of flattening for those two meridians is significantly different. The disease detection indices we know tell us when we're dealing with normal or abnormal eyes or something in between. Of course, green would be considered an indice within the normal. Yellow would be suspect. Red would be over the threshold of abnormal. So this eye is coming up with a couple in the yellow, but I think we're just reaching a higher threshold of normal rather than a truly asymmetric or diseased eye. Now these attributes, the sag differential, we said tells us when we need a toric or symmetric. The pupil width, super valuable to us because whenever we're fitting any kind of specialty contact lens, it's helpful to know what kind of pupil we're dealing with. If we're hoping for good myopia control with an Ortho-K lens or a soft multifocal lens, if we're dealing with an incredibly small pupil, how are we going to push the aberrations into the eye that we need to on such a small pupil diameter? So of course, pupil width matters. If we're fitting a presbyope, the same story. We need to know what optics are being placed within the diameter of the pupil. So it helps us to understand the distribution of power within our multifocal lenses, compare that to the measured pupil size. If the ad's going to kick in at 4 millimeters, that's not going to be helpful as a multifocal lens for the patient if their pupil's only 3.3. Visible iris diameter, similarly, I think it's one of those things, it's the least used parameter in any kind of custom lens, but it helps us so often. In soft lenses, 1 in 4 patients, 25% of patients fall outside of the diameters of our conventional big box soft lenses. So what are we doing for a portion of that 25%, if not all of the 25%, when it comes to the really big and really small eyes? Now, the estimated height chord attribute is one that I hope all of you have. It is a really cool and efficient tool that helps us with our scleral lenses. It stands for estimated height. So what Medmont does is it looks at the peripheral corneal shape of the eye, where the cornea begins to form a more angular surface, and that angular or tangent type surface runs itself right through the limbus and on to the conj till about 20 millimeters diameter. So if you can predict the peripheral corneal shape with a high degree of accuracy, you're more likely to be able to predict the entire anterior chamber, the entire depth of the front surface, and that can be beneficial when we're fitting a scleral lens. So as an example, the lens I use is a 14.8 diameter of sag. I'm sorry, let me back up. The lens I use is a 16.3 diameter vaulting scleral lens. Its sagittal depth is measured from 14.8 millimeters diameter. So if I know where the sagittal depth of the lens is created, then I can ask Medmont to tell me what sagittal depth am I dealing with to place that lens on eye. So for example, here I've set the diameter of measure at 14.8, and it's telling me across a 0-180 meridian, the eye depth is 3,533 microns. If I go to the 150-330 axis, a lot higher at 3,619 microns. So if we take an average, it's somewhere between 35 and 3,600 microns. If you add your fluid layer that you want between the lens and the eye surface, let's say 300 or 400 microns on application, we would want a scleral lens of about 4,000 microns. So using this EH chord attribute is a helpful tool to predict your first initial scleral lens. You don't have to do a whole pile of OCT calculations of the anterior chamber depth. You can just use your Medmont, do a composite capture, and set your chord. Now what you need to do is you need to know from the scleral lens you use, where does it calculate its chord of measure? So when it says that it's a sagittal depth of 4,000 microns, is that 4,000 microns measured to the tip of the lens? Or in the case of the ICD and the CAT lens in Australia and New Zealand, it's a 16.5 millimeter diameter measured to a 15 millimeter chord of bearing. So those are some of the things that might help to be more efficient with your scleral lenses. Now, another one of the attributes that I'm using with greater frequency is the high-order aberrations. When we're following a patient for myopia control, it's beneficial to know that we're increasing the spherical aberration, we're increasing the coma, we're increasing the aberrations in general. So understanding that change and ensuring that it's going in the direction that we want to becomes an important finding relative to myopia control. Now, the last one that I've got on my main window is an attribute that we've created to give us specific information for the lens we use. So this is one that you can create yourself, and it will provide you with the data that you want to pull out most frequently to enter into your lens design software or any calculations that you're doing on a contact lens. Now, the next consideration is we talked a little bit about pupil size and how important this value is, and really understanding the action within this pupil is a very important finding for virtually any contact lens, and certainly for irregular corneas. So we want to focus in on this dark shaded area where Medmont defines the diameter of this pupil. So if, for instance, we were to look at the flat meridian of this eye, we can say across the flat, there's this very supersymmetric eye shape, that there isn't a great degree of irregularity here. But when you take your axis line to the vertical, you notice this huge distribution of power. We go from 53.5 diopters down to maybe 34.5 diopters. So what's that, about 19 diopters of power distributed from the steepest point to the flattest point. How's that patient supposed to refract to any high level of visual acuity? You know, we really would expect rigid lens optics of some sort, a piggyback lens, a corneal GP, a hybrid, a scleral, something with rigid optics may be necessary to provide a decent level of visual acuity here. Now, there's a way to highlight the visible iris, and years ago, Jason showed me how I can go up to annotate and click iris and just draw this circle out to the borders of the visible iris. And what that does is it ends up populating that measurement on your main attribute window. So if you're ever wondering, why does the HVID never show up? And it's because you simply need to go up to annotate and click iris, and then that will help you to define the true VID. Now, this is helpful related to the contact lens software, because what it does, when you define the VID, it tells the Medmont software where the limbus is, or a ballpark figure on where the limbus is. So when I use the contact lens software and I place a small 14.5 scleral lens on eye on this huge 13 millimeter cornea, you can see by this blue border where the visible iris has been defined. And you can also see in relationship to where the scleral lens's point of greatest bearing is, how close that will be to the limbus. And if our goal is to protect limbal stem cells, our lens is awfully close to the borders of visible iris and the assumed area of the limbal stem cells. Now, that large diameter of eye really becomes obvious when we're using a small scleral lens. And if we use the contact lens software and settle that lens in 125 microns, the average settling of a scleral lens, we notice that our lens has sunk right into both the cornea, the limbus, and the conj. This would be a lens that's going to be grossly staining the peripheral cornea and the conjunctiva over the limbus. This would be a terrible fit. So by defining the iris, you can get a sense of how big a diameter of scleral lens will I need in order to clear the tissue that I really want to. A vaulting scleral lens, of course, should clear cornea, should clear peripheral cornea, should clear the limbus, should clear the initial part of the conjunctiva before it lands well out past the limbus. So in this case, using the visible iris definition really helps me to determine how much bigger a diameter of lens do I need to go to get beyond the borders of this cornea. Now, for those that are brand new to your Medmont and maybe new to orthokeratology, one of the things that you need to do, and Jason may set this up for you, or your distributor may set this up for you, but make sure that you've done this. And this is to adjust the scales on the subtractive map. So here you compare before ortho-K, after ortho-K, and the difference. And the default difference map is a scale of +10 to -10. So it's a very broad scale when you're thinking about most ortho-K patients. The average power, or the average refractive change we create in an ortho-K patient, or maybe better put, the average RX of an ortho-K patient is in the neighborhood of 2.5 diopters. So we're going to create 2.5 diopters refractive change, but we're going to have a scale that might be way too broad for the effect that we're creating. So what you want to do is create your own scales. You want a wide range to cover the various ortho-K effects that you're going to target. Maybe you're fitting 1 to 2 diopter myopes. Well, I want a low scale for that. Maybe you're fitting a 6 diopter myope. Well, you want a higher scale for that. So this is a good example where if I change the scale to the 6 diopter and go +6 to -6, now I'm starting to see a little more action in the center of this topography because I've tightened up the scale here. If I go down to a 3 diopter scale, now it's a more obvious bullseye. So I get a very good understanding of where are the peaks of the effect, where is the greatest flattening on this epithelium. I can tell whether the treatment zone is centered to the pupil. I can tell the size of the treatment area. If it's too small for this pupil, and this is an adult, and we have aberrations, I know that the treatment area needs to be expanded. So this scale adjustment is really important related to your ortho-Ks and following refractive surgeries or any of your disease patients if you're trying to pick up little nuances of change between this visit and this visit. Now let's change the scale to 2 diopters, and I've really overshot the amount of effect. Notice that we have a 2 diopter scale, plus or minus, but my effect is actually 2.5 diopters. So we're not seeing the peaks of the effect. My scale is too tight for this eye. So having multiple scales is going to help whether you're dealing with a low myope or high myope, because it'll give you the definition that you want. In this case, we have a 2.5 diopter refractive change in our ortho-K treatment. A 3 diopter scale is the right one. If I had a 4.5 diopter scale, a 4.5 diopter refractive change, then I might want a 5 diopter scale selected. Now, related to ortho-K, here's an outcome. And what would you call this? Is this the bullseye that John Mountford described to us so many years ago as the optimal topographical ortho-K outcome? Is this a high riding, low riding, nasal, or temporal? And I think we'd all agree that this is a pretty good outcome. The blue bullseye looks well centered to the black pupil. When we look at the baseline eye, look at how droopy this pre-treatment cornea is. So we expect that lens to want to ride kind of low. And our lens is actually, it's riding a little low, but it's actually centering quite well. I'm pretty happy with this outcome. So could we agree that this is a nice bullseye topography? And I'm hopeful that we all think that we did a decent job here. We could argue that the blue treatment zone is a little small relative to the pupil border, and that might introduce aberration for this patient. So for an adult, maybe not so good. What about for kids? Is this a good myopia controlling outcome? If we agree that this is a good bullseye outcome, it's a good ortho-K, is it a good myopia controlling ortho-K? And what can you look at to make that determination? Well, let's focus again on the pupil. Such a simple thing, understanding where the pupil is in the border, but let's go down to this gray area on your graph here. And when we highlight the powers that are distributed across the pupil, we can see how the most effect is here in the center, and that Ortho-K treatment gradiates out as we go away from center. So we're getting approximately 3.64 diopters refractive change right here on the visual axis, right here on the center of the topography. But at the pupil border, we're close to 0. So there is a shift in power of about 3.62 diopters. We have effectively a 3.5 add that we've provided this patient. So if you think about this related to soft multifocal lenses for myopia control, would you put a 1 add lens on a child that you were trying to slow down eye growth, or would you put a 150 add or even a 2 add? I mean, would you not be trying to push as much plus into the eye as possible? When we talk to the experts like Earl Smith III at the University of Houston, one of the world's myopia experts, he says push as much plus into the young eye as possible to slow down the eye growth. If we look at the work of Stephen Vincent there in your area of the world at QUT, and his work on aberrations to help us understand how important increasing spherical aberration is in slowing down eye growth. The higher the spherical aberration, the less the eye grows. So this number is important because we're showing the shift between most minus and most plus. We're showing the add that we've created for that eye. Another way we could look at it is to use the numeric meridian map, something I rarely use in the Medmont, but it's helpful related to myopia control. If you look at the values, some practitioners like to have the curvature values all over the topography. In this case, we have a subtractive map showing us the most minus effect down to the least minus effect. So if we blow that up a little bit, you see that from this point on the visual axis, this patient goes from 3.8 diopters RX change down to 0.1 positive change. So there's a 3.9 diopter power change, or 3.9 diopter add we've created along this radial. If we go from center to the temporal side, 3.8 down to approximately 0.8, we've created a 3 diopter add. Center to the nasal side, somewhere around a diopter, so a 2.8 diopter add. So this is a very good myopia controlling outcome, or at least topographically, we would presume this would be an optimal effect. Now, in the past, I didn't use the wavefront analysis that the Medmont did, but today, increasingly, I'm looking at this. Again, referring back to Stephen Vincent's work and his colleagues at Hong Kong Poly, they suggest to us that we want to follow the spherical aberration, that we want to see the increase in spherical aberration. In Stephen's study, he said that really the anterior surface wavefront is not the whole picture. You need to understand the total aberrations of the eye. And as you may know, the Medmont is an anterior surface analysis. It understands what's happening on the corneal surface, but not beyond. So do the wavefront aberrations have value to us if we really need the total aberrations? And I would suggest for those that don't have a aberrometer, at least you understand, if I'm doing Ortho-K for myopia control, am I seeing the spherical aberration going up significantly? That's what we want to happen in myopia control. If we were dealing with an adult Ortho-K, of course, we wouldn't want those aberrations going up through the roof. That's going to limit the quality of vision, especially at night. So the wavefront analysis is one of those tools that you might find you're using with a little more frequency. Hey, last was, I know there's many experts in topography on this call, and you've got some great teachers and people like Jason Anderson who will communicate to you your ability to take your topographies, create a digital file. So highlight the maps you want to share with the lab, go up to File and Export. That'll push that data into creating a little export file. In this case, these 4 topographies create a 3.1 megabyte file, certainly big enough to email. We can email that off to the lab. The lab can use that topography to import into their Medmont software or into their third-party softwares to build whatever type of specialty lens. So this way of connecting with your lab is so important. Whatever you do, do not send a PDF of the topography. That does not give the lab any additional information other than the general appearance of shape and maybe the K readings. What you want is send them the elevation, send them the shape data, send them all the information that a Medmont will provide. And that helps them to better construct that initial lens. Hey, we talked about a wide range of stuff. We really sprinted through a whole bunch of concepts. If you weren't aware, on the Medmont website, there's a whole bunch of different videos that are a little more in-depth on specific areas, like contact lenses, like building a rigid lens, such as analyzing pre and post ortho K shape. So go to the Medmont website and you'll find a slew of videos there that might be helpful to you. I want to thank Jason for setting up this session.
Well, I think that concludes the webinar for this time round. Please join us again on Tuesday, May the 19th, 9 a.m. Australian time, and that will be 11 a.m. New Zealand Standard Time. So again, join us for more insights on what the Medmont E300 corneal topographer can provide you and your patients. Thanks again.